Well, welcome to the Disney room. I hope we don't think of this as some kind of fairy tale we're going to be talking about here. We're really lucky to have Dr. Azra Raza here, who is a professor of medicine at Columbia. She sees patients. She trains the next generation of physicians. She has a basic science laboratory. She also is the clinical director of the Evans Foundation MDS Center and the executive director of the First Cell Coalition of Cancer Survivors. And she's published a book on poetry, and she found time to write a book. And Azra, as a cardiologist, I have to ask you, are you getting your 30 minutes of exercise every day? I don't. And 7 hours of sleep at night? I'm not sure that works. You know, she's clearly, Thomas Jefferson got it wrong when he said, all are created equal. I don't really think so. But tell us about this book that you wrote. Tell us about the first cell.
The first cell really is described by the subtitle, because the subtitle of the book is, "And the Human Costs of Pursuing Cancer to the Last." So it's a book about cancer and why finding cancer early at the first cell stage is important.
And what motivated you to write this, Azra? Sorry. What motivated you to write this book?
You know, there's a sentence in my book that appears twice. It's the opening sentence of the book, and it's also in the epilogue of the book. And the sentence is that I could not have written this book when I was 30 years old. It's not because of the great papers I've published or wonderful discoveries I've made in the intervening decades, but it's all about the nature of lived experiences, where I've had to take care of thousands of patients with a particularly deadly form of bone marrow cancer, acute myeloid leukemia, and walked most of them to their deaths. And the thing that is most frustrating, that some of the factors that pushed me to express my frustration in the book finally, is the fact that I came to this country in 1977, and the two drugs that I was using to treat this leukemia, we popularly call them 7 and 3, 7 days of one, 3 days of another. In 2023, we are using 7 and 3 still.
You came was famously in the early 70s, President Nixon had declared this war on cancer. So we're just beyond the 50th anniversary of this war. How are we doing with this war?
Well, a couple of things about the declaration of war on cancer. He used exactly 100 words to declare the war. But what he promised was that within 5 years, which meant he declared the war on December 23rd, 1971. And it was, he said, within 5 years, we will eliminate cancer. And that message was misunderstood. Of course, 1976 came, Nixon was no more, cancer was still being cancer. And 2023, the same thing is still there. So the misunderstanding in that message is not that we will understand cancer, but it was we will eliminate cancer. There's a difference, because we don't understand everything about malaria, but we can eradicate it. We don't understand everything about many diseases. Without understanding, we've been able to get rid of many things. My point is, we have been victims of great arrogance in thinking that we can unravel the deep and profound mysteries of how a cancer cell behaves, and we will be able to fix it by going back and correcting every mistake. But if you think about, even a normal cell has 1 trillion molecules inside a liquid surface that are talking to each other, communicating, all kinds of complicated things going on. It's impossible to understand. But my point is, can we just find the first cell and eliminate it and prevent cancer from becoming this end-stage monstrosity that is almost impossible to deal with? So just I'll end by saying the last thing, which is that you said Mr. Nixon, President Nixon declared war in 1971. Where are we today in cancer? In the age-adjusted mortality from cancer today in 2023 is the same that it was in 1930. I cannot make up these statistics. Think of the following. Sure, we are curing a lot of cancers today. 2/3 of cancers practically which are diagnosed are cured. But number one, they're cured because they are found early in this stage. For advanced disease, if a person has advanced pancreatic cancer today, their outcome is no different than it would have been in 1930. So that's number one, early detection. Number two, what are we using to cure cancer? Slash, poison, and burn. Surgery, chemotherapy, and radiation therapy. So where has $1 trillion gone in research that was promising these personalized, precise therapies for us?
I was speaking with one of my classmates from medical school who went into hematology oncology and trained in New York. And he said, and about this talk, and he said, Khoi, I really feel like you could have put me in a time capsule when I finished my training, and you could wake me up now, and I'd still be a pretty good doctor with cancer. Is that, he said I'd have to learn a few things, but not much. And he talked about 7+3, that a lot of the principles are still the same.
Not only that, Khoi, think of it. I had recently a patient who was dying of leukemia. And in the end, she had such severe, horrifying bone pain. And the thing that gets me is that not only have we not cured cancer, we are using the same 7 and 3 for leukemia. In 1977, I was giving morphine to control pain. Today, I'm still using morphine to control pain. And number 3, when we give chemotherapy, everybody's blood counts fall, and they become susceptible to infections. They run fevers. When they develop a fever, basically, in 1977, we were throwing the kitchen sink at them. Antibiotics, antivirals, antifungals, everything we could give them. Today, in 2023, the same. So it's not just that we have an improved cancer, but the treatment that we are using causes such severe problems, we are still using the same treatments for that.
But we don't want people to get too depressed here, Azra. I mean, there are some things that we're better at with supporting people who are, keeping their counts higher, right? We do have things to stimulate the bone marrow to produce more red cells, more white cells, more platelets. We do have things that we didn't have in the 70s when you came. So there's been some incremental, I think you would call it. Yeah. But and some cancers we've made tremendous progress, melanoma.
Yes.
But there are some that we are not making progress. And why do you think that? Because there's how much money has been spent in cancer research over the last 50 years? Half a trillion? I don't know. What's the number?
Well, the number is because if you look at just the government spending, it's about $250 billion. But add to it philanthropy and pharmaceutical industry investments, etc., it's about $1 trillion.
And so we don't have that much to show. Is it that we're doing? You suggest in your book that some of the core tenets of our research, mouse models, that we're really pretty good at treating rats, I think, right? You know, if you've got a mouse with advanced cancer, we've got a lot of published studies showing that we get great results. This is the rat problem in New York. I think you've got really good.
Listen, one of the reasons I'm sitting on this stage is thanks to a mouse. And that is because in 2015, John Brockman, who's a very well-known book agent, he was in fact the agent for Andy Warhol, a very famous guy. So he gives out a question every other year to like 100 intellectuals around the world. And in 2015, the question was, what scientific idea is ready for retirement? So my answer was, the real elephant in the room is the mouse. Because the mouse model is ready for retirement. Like Khoi said, we were curing acute leukemia in mice in 1977. And yes, the subways in New York are the best proof of that. But today, we are still struggling to make any advance in this particular cancer. So mouse models gotta go. I have a very straightforward solution that I have been proposing since 1984. And it's just so commonsensical. Within a few years of treating acute myeloid leukemia, it was very obvious to me that in my lifetime, this disease will not be cured. It's so complicated, so vicious, so malevolent a disease. So I said to myself, we should be trying to find it early, but how do you find a leukemia early? Well, the only way is look at people who are at high risk of developing this cancer and start screening and monitoring them till they develop cancer. So I went and looked, and sure enough, there is this pre-leukemia, the condition called myelodysplastic syndromes. And I said, wow, this is where I need to start. Start studying people with pre-leukemia, follow them and see how they develop make this phase transition into acute leukemia.
Some people here may have heard the diagnosis MDS, and I just want to give them perspective. What percentage of MDS patients will progress to a more malignant course?
Let me say this, 100% of MDS patients will have lower blood counts of one sort or another. And people who die of this disease, 2/3 of the time will die of MDS, and 1/3 of the time they'll progress to an acute leukemia and die of it.
Die of MDS or die with MDS?
So that they all die of low blood counts. They die of bleeding or infection because the blood counts have fallen so low since the whole bone marrow is replaced by.
So you took it on yourself to really study it upstream.
I was telling you that so the reason I felt very strongly about one thing was that we need to diagnose it early. But the second was, okay, now how am I going to diagnose it? And that's the real important issue that occurred to me in 1984, that if I'm going to study and do something serious in this disease, then I need to have patient material. And so I started saving blood, saliva, bone marrow aspirate, biopsies on my patients and just banking them.
The tissue repository.
The tissue repository that I started building up then. So my two important findings were diagnose early and only study human disease to cure human disease. And so the mouse model was the real elephant in the room for me. And when I answered this question and wrote a 1,000-word summary about it, you'll be happy to know that mine was picked up as the #1 answer and made the headline in The Guardian. I beat Richard Dawkins, Steven Pinker, Daniel Dennett, all these famous people with my mouse model condemnation. And then John Brockman, the literary author who's a friend of mine also, would come over to my place often for dinner, and he goes, Azra, you keep harassing us about the mouse model and all that's wrong with cancer. You got to write a book. And I keep telling him, no, I'm not a writer. I'm here to cure cancer. I can't waste my time writing. He's the one who forced me to write the book.
A couple things to follow up with what you're saying. The mouse model, I understand it wasn't just a research tool, but until very, very recently, didn't the FDA actually mandate that it be included in some kind of drug development issue? Isn't
Yes,
right?
there was a law that was instated in 1938 that before we bring any drug from the bench to the bedside, we have to test it in animals for toxicology, for efficacy, and all that kind of thing. And so this is how, gazillions of dollars are wasted on testing drugs in these mice. And mice are dying. It's really sad, but then they have no significance for the human body. And so I think...
You're just saying that because we're in the Disney room.
Yes. Good one. Yes, Mickey, this is directly for you. But the truth is that, yes, I feel that something, a very small role perhaps that I have played in raising awareness about the absurdity of using these kinds of models is the reason behind President Biden 2 weeks ago signing an order destroying and rejecting this bill from 1938 to now. And so now we don't have to do that.
And the other thing I wanted to follow up with, you talk about this tissue repository that you've created, and can you let people know the scope of this? How many samples have you collected?
Over 60,000 now. 60,000 samples from thousands of patients who have been serially studied as they traverse the natural history of their illnesses, from pre-leukemia to acute leukemia.
And this is all done personally. I don't think a lot of other clinicians have contributed to this.
Not a single cell comes from another oncologist. I still do the bone marrows myself. Now that I'm an old hag, I have to use an electric drill to do the bone marrow, but I still do everything with my own hands. I draw the blood on patients myself, because as soon as you say the word research, you have to pay for everything yourself, because no one else is going to pay for it. So you have to pay for from the moment that kit is opened and you draw and somebody carries everything, and has to be done by me.
So you can do the math on how long it takes to get 60,000, and we will be expecting you to leave the room in single file.
And don't try to calculate my age by dividing 60,000.
And we will be taking a few samples on your way out as well.
No, it's a very painful procedure. And I'm hoping that within the very short time, we are able to now obtain from 2 drops of blood more accurate information than we can get from bone marrow biopsies. And I hope when these things very soon come out, my patients will be spared this nasty and painful procedure.
Azra, could I, some of the people in this room probably have heard of the GRAIL test, the blood test to try to detect cancers early, but it seems like that's still fairly controversial, and I know maybe you need a disclosure because you're probably on the
Yes.
board of this,
Yes.
but do you feel comfortable talking and making a recommendation?
Since I condemn everybody, yes. No, just kidding. Yes, I am on the board of the company GRAIL, which is completely focused on trying to find cancer early through liquid biopsies. That's my disclosure.
Yeah. And so can you tell us what the test is?
Yeah, the test is very interesting. Remember when women who would get pregnant after 30 years of age, we had to undergo amniocentesis. I had to undergo an amniocentesis, and that meant taking this huge long needle and thrusting it into the uterus and getting out the amniotic fluid and testing it for any fetal abnormalities by looking at chromosomal damage. Well, it turns out that you could detect fetal DNA from the fetus in maternal blood. So when that became possible, this was called fetal cell-free DNA. That you don't have to insert that long needle, you just take 10 cc's of blood from the mother and look for the same abnormalities you were looking for, and wow, you have the answer. So it occurred to Rick Klausner at Illumina that if we can do this, why not try to look for cancer the same way? And cancer cells, when they die, they shed proteins and pieces of RNA, pieces of DNA, all kinds of debris into the blood. And that's why it's very important to think of looking at blood as a window into all kinds of diseases, because the footsteps and the footprints are there. So people started finding little pieces of DNA that are shed from cancer cells and finding them in the blood. So suddenly you say, oh, I got this blood sample from a patient who's perfectly fine, is here to see me for a heart disease, but now I'm finding footprints of cancer. Where is the cancer? Is it in the lungs, brain, pancreas? Where is the cancer? So yes, you could find pieces of DNA, but you didn't know where the cancer was. If you did scanning and imaging, it was too early to detect. So then people figured out at Grail a new technology which uses methylation methylation patterns of DNA to show the. Do you know that every cell in our body has the same DNA, whether it's a brain cell, an ovarian cell, a lung cell, but brain cell becomes a brain cell because the other genes are silenced. Only brain cell genes would be active. And that silencing and reactivation is done by a process called methylation. So you can find these methyl groups. In other words, every organ has its own zip code of methylation. So you can take a piece of DNA and you can tell, is it coming from the liver? Yeah, because these genes are activated and these are silenced. It's a beautiful method. Grail is the company that developed this method of using a methylation platform to take a piece of cell-free DNA and figure out that it's coming, oh, this one is coming from somebody's kidneys or somebody's lungs. And so you now know. The problem with the test is, and I'm a great proponent of early detection, and this is a great first step, and even though I'm on the board of the company, it's because I'm there to tell them what they have to improve on. And one of the things is that even with this technology right now, sure, 99% of stage 4 cancers are detected by this technology, but only 30% of stage 1. So, well, you don't have to be a weatherman to know it's raining outside. No one needs to tell me this is stage 4 cancer. I need to know who has stage 1, and you are missing 2/3 of them.
So time to pump the brakes a little bit on Grail.
No, not at all, because what they are detecting are things for which there were no screening tests available. Because right now, the only things we can screen for, cervical cancer with HPV, mammography, PSA for prostate cancer, colonoscopy,
Skin.
uh, skin.
Skin exams. I mean
That's
so
exams.
yeah.
I'm saying
blood test, you say?
yeah,
or some
screening
kind of
test. And the last one, which is now becoming more common, is CT scan and imaging of the lungs for high-risk people who are at high risk of getting lung cancer, heavy smokers, COPD, etc., etc. But those are 4 or 5 cancers. What about other cancers for which there is no screening test? Well, this test can detect at least 1/3 of them, and that's huge. So this test by Grail, I recommend all of you to take it, but you have to pay for it yourself right now because no insurance companies covers it. Why is this test so important, even though it detects 30% of stage 1 cancers? Because it's a multi-cancer detection. It's not one diagnostic procedure for one cancer, but rather it's few drops of blood for 50 cancers.
I think it's about $1,000 for the test, and we'll have to talk to Jamie about including it for the Platinum Angels. I'm sure we can work something out with that. Your book is more than a call to action on cancer, though. I found, as a cardiologist, it was still so interesting to me because of the humanity in your book. And each chapter in this book bears the name of a patient who meant something to you. Yeah. And you weave these stories in and out beautifully. And think in other conversations you've had, you described one death in particular, Andrew's death, as being a real motivator for you to write your story. That, I struggle with as an oncologist, when you speak to a patient with a stage 4 cancer, Azra, and you try to guide people in whether to make a decision to go for more treatment or less treatment, to balance hope versus some type of acceptance. That, I don't think that was ever taught to us in medical school, how to do that. How do you navigate that emotional interaction?
I see 30 to 40 cancer patients every week. I have to say that I see the most beautiful side of humanity, the most noble side of humanity. Because these are people who have serious illnesses. They themselves rise to the challenge, and the dignity with which they bear it for the sake of their immediate family, for the sake of life itself, it's an exuberant feeling. So many people ask me, were you doing the same thing over and over? Do you ever get bored? Of course not. Because every patient has a new story to tell and a new way of managing. You said we are not taught this. We can never be taught something like this in school because there is no single formula by which we can deal with every patient. Every patient demands an individualized, personalized care. And for me, the most important thing is that, look, when you have a long life ahead of you, you can plan for things, you can hope for things. But when you suddenly get a diagnosis like cancer, now it's uncertain. Not every cancer, most cancer patients will be cured, I hope. But now when you don't have that luxury of time, suddenly now becomes important. You learn to make the most of time now.
But for that planning, I think of 3 things that physicians fundamentally do. We diagnose, and we treat, and we prognosticate. Fundamentally, these are our skill set, and we've gotten pretty good at diagnosis. I think we work hard on treatment, but we really are terrible at prognosticating, and I think the phrase that doctors say the most is, I don't have a crystal ball, and we almost shirk that responsibility. But for what the discussion that you mentioned, that's so important. If you're saying, yes, if you give somebody a certain amount of time, they can plan. That involves some prognostication. But I have to say, and that When Breath Becomes Air, right? I think so many of us have read that book, and I know you have as well. And Paul Kalanithi, he's given this choice. He gets diagnosed with a couple years left in his neurosurgical residency. And he says to his oncologist, if I have just a year or 2 left, I'm not finishing my residency. I'm doing something else with my, but if I have 10 years, then I'm going to finish my residency. And the oncologist says, you have a long time. So he finishes residency, and of course he dies shortly after. And he knows the last day of residency, when he closes that locker, he writes about, he listens to his favorite song because it's his last time and he knows it. And so that was, I feel like we failed this young man. It's one of these questions without a question mark at the end, isn't it? I hate those.
Being a cancer patient is something so weird, because I had been taking care of cancer patients for 20 years, and my own husband, who was head of the cancer center, who had dedicated his life to cure cancer, gets the very disease, leukemia, himself. And he was also my mentor, and one thing he had taught me throughout was never become too emotionally involved with your patients, because emotions cloud judgment, and you want to make completely unbiased judgments for your patients. So don't get too close. When his leukemia was diagnosed, the first thing he did was turn to me and say, "As you're going to take care of me." What are you talking about? You're the one who told me all my life that I'm not to. So he said, "Well, I'm sorry, I only trust your judgment." And even for myself, I have to say that until I shared a bed with a cancer patient, I didn't know how painful a disease it could be. And I'll give you one example of this. After Harvey died, after a 5-year battle, my daughter was only 4 when he was diagnosed. When he died, this poor 8-year-old, couple of weeks after he was dead, developed upper respiratory tract infection. Fever, coughing, pretty sick. Well, a few days later, she started getting better, and one morning I'm sitting in the living room working, and she comes out crying inconsolably. I was convinced as a mother that she's worse. I said, "What happened? Are you feeling worse?" And she said, "No." "So why are you crying?" After she could compose herself, this is what she said. She said, "Actually, I feel a lot better today, Mom, but now I know what it feels like to be really sick and how good it is to get better. And my dad never got better."
I think for me, one of the most moving parts of your book, and the most unusual, comes at the end, where you have these beautiful anecdotes, vignettes of these patients, Omar, her, Kitty, Lady, all these people, JC and Andrew, and you solicited, and this is several years later now, and you showed, I think, your manuscript to their surviving family members and spouse, and you had them read it and write you letters about their memories of that time and how they felt their loved one balanced hope and resignation. And that was very powerful. I think especially Omar, who's this young, brilliant person, literate, Oxford educated, I believe, and he died in his late 30s, had just been married. And you got letters from his mother, his brother, his sister, and his wife at the time. And they all had different things to say. I think his mother said, "I would never accept him not going for more treatment." And the sister said, "We failed him because we should have said, 'Beloved, we need to have a conversation as a family.'" And his wife had a different view. So it's so complicated, isn't it? It's not one way.
No.
And even in the same person, it's not one way from the different family members' points of view.
Yeah. Well, look, when I wrote this book, I'm looking at everything related to cancer through the prism of human anguish. What is cancer can be just a very odd word that you cringe from. But then it's something that affects not just the person but the immediate family, so much of life in general. So when I'm looking at cancer through what it's doing to patients, their families, their communities, the society, the country, the financial costs, the emotional burdens, the pressure of improving treatments, etc., etc., in the end, what can hindsight teach us? And so I write about these 7 patients in 7 chapters, and then I go to the families of the patients 10 years later, 5 years later, and tell them to now think in retrospect about what decisions would they have changed. now that they have the benefit of hindsight. And essentially, not one person said they would change much, because even though Andrew, diagnosed at 22, dying at 23, he was diagnosed with stage 4 glioblastoma multiforme, one of the deadliest cancers known to mankind. My daughter's best friend, not her boyfriend, because our Andrew was gay, but her best friend was in and out of my house throughout his young life. He gets cancer. From day one, every one of his treating oncologists knew that we cannot improve his survival by a single day. Yet what followed? Horrible treatments over and over that he suffered toxicities from, and the tumors continued to grow. His mother sees all this. 5 years later, when I ask her in retrospect, would you have done the same thing? She says, yes, because I was never going to accept that he is going to die. Even if you told me there's 1 in a billion chance that my son would do, yes, I would take that chance. And so it's a burden we are putting on patients and their families. It's up to us. We should not be abdicating our responsibility. Our responsibility is to do better for cancer patients today and do better still for cancer patients tomorrow. I'm not saying there are no advances in cancer, of course not. I'm saying there's pathetic little. Writing is on the wall, it's very clear. The only way to cure cancer is to find it early. And best find it early in people who are at risk of cancer, don't even have cancer yet, and prevent it from evolving right from that stage. Why aren't we doing it?
Just to highlight one of the points you just made about the financial costs of a cancer diagnosis that you point out in your book.
Yes, 42%. Think of this, practically half. 42% of Americans diagnosed with cancer today will lose every penny of their savings by 2 years. 42%. We are financially ruining people. And it would be worth it if it was curing them. That's the whole point. Let me say this. 95% of all drugs that are brought to the bedside today, February 1st, 2023, 95% of all drugs brought to the bedside of a cancer patient fail completely. The 5% that succeed should have failed because they improve survival for 30% patients by a median of 2.1 months. And for this, we are ruining them financially. Sure, people who are diagnosed early are cured, but still being cured with painful treatment. So I'm saying the 70% we are curing, we should be curing with better treatments. Why are we putting people through chemotherapy? That's Paleolithic. And the 30% who are diagnosed with advanced cancers that we haven't made a difference in since 1930 to today, we need to change that. We need to diagnose it early. So when I say all this, you know what happens, Khoi? There are 2 types of reactions. One is, oh, you want to diagnose cancer early? We already knew that. If you knew that, why are you studying end-stage metastatic cancer? Why are you not trying to find cancer early? Second reaction is just the opposite. It's like I've written the satanic verses of oncology. I'm completely ready to be stoned by a fatwa.
Another part of your book that's really wonderful is how you've laced it throughout with poetry. And some of it I actually understood. and I have a hard time sometimes getting poetry. But some of the Emily Dickinson poems, how did you come to have such a comfort with the word Azra?
I guess it came because of my family background. My parents immigrated on partition of the subcontinent into India and Pakistan. So my father was in the British Civil Service. He opted for Pakistan. They moved to a completely new country. And they developed the immigrant's anxiety, which is that, oh my God, we left thousands of years of culture, now we have landed in this desert, what's going to happen to our children? So it became very important for them to impart that kind of a cultural tradition. And we come from an oral tradition where poetry has a very big place. You speak about Emily Dickinson, and we were talking about Harvey, my husband, earlier on. After taking care of him, I can say, in Emily Dickinson's words, I measure every grief I meet with analytic eyes. I wonder if it feels like mine or has a different size. I wonder if they had it long or did it just begin? I cannot find the date of mine. It's been so long a pain. I wonder if it hurts to live and if they have to try. And whether, could they choose between, they would not rather die. Poetry says so much to me in a few words that I feel like the double helix of the DNA is like the two lines of a couplet, that it's a macrocosm contained in a macrocosm. Microcosm. As you said earlier, how do you talk to patients? Another one of Emily Dickinson. I can end with that.
Tell its land.
Okay.
Tell the truth,
Okay,
but tell
that's
its
a
land.
good one too. All right, I'll do that.
Yes, please.
Okay, I was going to do another, but since you asked for it, maybe we have time.
Just talk fast.
So, Khoi had asked me, how do I speak to patients about their terminal illnesses and prognosis, etc. And Emily has such a gorgeous way of saying it. Tell all the truth. I mean, look at her admonition. Tell all the truth. You can't hold anything back. Tell all the truth, but tell it slant. Success in circuit lies, too bright for our infirm delight, the truth's superb surprise. Like lightning to the children, eased with explanation kind, the truth must dazzle gradually, or every man be blind.
That's wonderful.
Thank you. Thank you so much.
Oh my goodness, we are clearly not all created equal. Thank you, Azra, for coming and sharing your humanity with us.
Thank you so much. Thank you.